you, ladies and gentlemen. Can hear that song that menopause is battering many women. So this talk today is about menopause. As I go through preparation for this talk, I realized that menopause is such a huge topic. You cannot cover it in one webinar. So I decided to divide it into 3 parts. Each webinar describing certain parts of menopause in my endeavor to educate women about this huge topic of menopause. So today is part 1 of the 3 parts. And as you know, my name, I'm Dr. D T Mahapa. I'm a urogynecologist situated here in Polokwane. So today, please welcome you to part 1 of the 3 parts, menopause. Each part will be describing certain aspects of menopause. People want to know where I come from. I come from a very beautiful area. This is Majijile. That's a rural farm, very beautiful area, where there are a lot of women with menopause. The aim of this is to reach Majijile and far below, not only urban people. We reach even areas where they use data for connectivity, no Wi-Fi's. And you know, the women in menopause are usually elderly women. So while we want to women who are playing this, they are strong. You know, I must declare that as much as I've been giving other webinars, I am a full member of South African Menopause Society. There's a big society in South Africa, which is South African Menopause Society, which one of the aims and objective is to create awareness to women themselves. It's not just to study menopause at the academic level, but to create awareness to women and try to reach them so that we can dispel whatever information which is incorrect or incorrectly received or delivered to them, the myth and taboos. So it is my role as a member of South African Menopause Society to give you the correct public education on this subject. This society, which is South African Menopause Society, is trying as hard to reach as many women as we can. And I think this webinar is one of the methods. We are using many methods to reach them. And this, I hope, it will reach as many menopausal women as possible. This year, February, we had a very fruitful and enriching conference in Pretoria under the leadership of our president, Professor Dineo Matsela, who is a professor at the Medical University of Southern Africa, which is now called Sefako Makgato. She organized herself and his committee organized a very marvelous. They did a marvelous job in organizing an eye-opening conference where one of my take-home messages, I had many take-home messages there, was to take menopause education to the women themselves. We study a lot of biochemistry, the mechanism, the pathophysiology of menopause, but do we reach the information to the women themselves? And this is one of the methods that we can reach there. And in one of the paper, their statement, they said they want to dispel the unscientific management of menopause. People have got over-the-counter management of menopause, myth and taboo, and they end up using unregulated compounds, which are called bioidentical compounds, because the word bioidentical, it fools you. You think these things are biologically identical to hormones. They are not. The word bioidentical is just a marketing word to fool the public. So the society is much concerned about the quality of these products that people are using, the safety, the efficacy, and the potency, even sterility, as these compounds, they are not regulated by the regulatory body, the SAPRA, which regulates the manufacturing of drugs in South Africa. So we try to dispel this misinformation about compounded product and advise the use of evidence-based information. As I said, the word bioidentical is not a scientific term. It is a commercial marketing term to catch unsuspecting vulnerable menopausal women. But In this part one, we're not going to discuss the treatment, which is HRT. I think it's on the part three where we'll be discussing the treatment and we'll give the correct treatment that are evidence-based treatment. Let's get into introduction. The topic is menopause and climacteric because I put it so deliberately because people tend to think menopause is climacteric. Climacteric is a phase in a woman's life, a phase in the aging process of a woman that marks a transition from reproductive age of life to the end of reproduction. Because then climacteric can spend over several years, while menopause, the word menopause just marks the final menstruation, final cessation of menstruation. When the final menstruation is on this date, that's the beginning of menopause. Menopause is not a phase. It starts at the last menstruation. The climacteric does not necessarily have symptoms, but in some women it can have symptoms, which are menopausal symptoms. If climacteric does have menopausal symptoms in a woman who has got hot flashes but is still menstruating and still a potential of having pregnant, that phase is called climacteric symptom. And there are so many somatic and psychological changes that occur during menopause. Some of them, or most of them, are due to estrogen deficiency, which is a consequence of ovarian follicular exhaustion, while others are just the results of aging processes. The estrogen that I'm talking about is the main female hormone that's produced by the ovary. So this presentation or webinar is about a woman who is passing through climacteric into a permanent state of menopause. So we must differentiate between menopause and climacteric. Climacteric is a phase, while menopause is a cessation of menstruation. Climacteric is a stage between reproductive phase and non-reproductive phase. We know that during menopause, there's no more reproduction, can't fall pregnant. As you go into that phase, you are in the phase of climacteric. Climacteric usually it ranges from 46 years to 55 years. 46 years to 55 years, it doesn't mean the woman is totally infertile, but fertility is so low that it's going towards non-reproductive stage. And at that stage, majority of women, because nowadays women follow career, they still want to have children. They can still have a chance of having children. Besides, they must be warned of the fact that they might have chromosomal abnormalities like Down syndrome, but it is not a contraindication to fall pregnant. If menopause have symptoms, climacteric have symptoms, it's not called climacteric, it's a syndrome of climacteric, it's preparation for menopause. And during that climacteric, the cycles, or the menstrual cycles, majority of them are unovulated. You don't ovulate. You've got a cycle every month you bleed, but there's no egg that's being produced. So the chances of falling pregnant are minimal. Majority of the cycles are unovulatory. And mostly in a woman who has had a regular menstrual cycle, you start to realize that the cycles start to be irregular. She cannot tell exactly when she's going to menstruate or the week she's going to menstruate. While during reproductive phase, she could know that this week I'm likely to menstruate and she will have premenstrual symptoms. And the menstrual flow during climacteric, because of decline in estrogen level, is scanty. It's always scanty. It's not as heavy as it used to be. If you used to menstruate 4 days, you must menstruate 3 days or 2 days. Just if you used to use 10 pads, you have to use 3 or 4 pads the entire menstruation. And those such women are not infertile, as I've said. They are fertile, but their fertility is so reduced that they are regarded as subfertility. We find a woman of 47 years looking for a child. You advise her that most of your cycles are unovulatory, but if you give ovulation induction, you might have a baby. Besides that, she must be warned that she will have to be investigated for chromosomal abnormality. I'll explain why later. Let's go to the physiology of menopause. Touch it a little bit. You know, a woman's life expectancy is longer. Most women will live 78 years or more on average. And we said that menopause starts at about 50, 51 years. So, which means if a woman has had menopause at 51 years, she's going to live about 1/3 of his life during menopause. About 28 years of his life, of her life, will be in menopause. So she should know. The reason why I said I was going to explain, to explain why a woman at around 45 should not have children, should have abnormality, is because at birth, a woman and a man are different. At birth, a woman is born with about 400,000 eggs in both ovaries, while a man at birth is born with no sperm at all. She will start producing sperms at puberty, and every 72 days, sperms dies, he produces another one. A woman doesn't produce new eggs. You are born with those eggs. If you are 30 years, you must know your eggs are 30 years old. So by the time she's 45, those eggs are 45 years old. That's why they are prone to have chromosomal abnormality. They are old eggs. And these eggs, every month as she menstruates, some eggs they develop, others become dominant follicle, which is ready to be fertilized. Others, they go at the process called atresia. They just degenerate, such that by the age of 35, the number of eggs that are there in most women is half of the number of eggs that she was born with. It's about 200,000 in both ovaries. So by the time she reaches 45 years, which is within climacteric, she has only about 500 eggs. You can see that the chance of fertility is reduced so much by the number of eggs that she's having at that particular moment. And then by 50 years, 51 years, they are depleted. There are no more eggs. And if there are no more eggs, there's no hormone production because there's no egg to be produced. So you start to have hormonal changes. The follicles, these which are eggs are follicles. Eggs are produced in the follicles, is stimulated by a hormone called follicle stimulating hormone, FSH. It starts to raise up in an attempt to try to stimulate eggs, but there are no more eggs there, so the level will just be high. And once you stimulate eggs, if there are follicles, the follicles will produce estrogen. Estrogen will do what you call positive feedback. If there is enough estrogen, FSH goes down. But because there's no follicles to produce estrogen, the FSH become elevated and estrogen become less. That's how they test whether you are in menopause or not. They test your FSH and the estrogen level. If the estrogen is low, very low, FSH is very high, it means you are in menopause. So you'll have those shorter irregular cycles which are anovulatory because there's no eggs to ovulate. Let's touch a little bit of endocrinology of the menopausal ovary. You know that we said in premenopause, estrogen is the mainly produced in the ovary. Before menopause, during the reproductive phase, estrogen is a hormone that's produced mainly in the ovary. After menopause, there's no more estrogen. The main hormone that's produced by the ovary is called androstenedione. And this androstenedione is not a female hormone, it's an androgen. It's mostly found in male. So you start to produce more androgens than estrogens. You produce more male hormones than female hormones. But luckily, some of this androstenedione, male hormone, can be converted in the skin or in the fat into an estrogen type, which is the first phase precursor is called estrone, which is later converted into estrogen. So postmenopausal estrogen, the amount of estrogen that is there, it's not mainly produced in the ovary. It's produced by peripheral conversion of androgens, male hormone, into estrogen. So this way, it's not that high. It doesn't mean that a woman in menopause got no estrogen at all. She has got estrogen that is produced by conversion of androgen into estrogens. Around menopause, in perimenopause, there's a transition that takes place. The woman changes from normal ovulatory cycle to complete cessation of menstruation. And this, as I said, is marked by climacteric syndrome, which is characterized by irregularity of menstruation, scanty menstruation. And this can start about 5 to 6 years before menopause. And before even the onset of menopausal symptoms, only majority of women will have onset of menopausal symptoms around 50, while others will still have them during climacteric. That's what we call them, climacteric syndrome. The word menopause itself is a Greek word. It derived from a Greek word called menus. Menus means months, and pauses means cessation, which means cessation of months. We knew that every month a woman menstruates. In our mother tongue, they call it ubonafwedi. And what kind of months is that? When they say months, they don't mean calendar month. They don't mean January, February, March. They mean lunar month. Lunar month, the elderly women before education, they knew that every month when the moon is this side, I'm going to menstruate. They were using the moon because a lunar month, every 28 days, a moon is at a particular level. So they mean lunar months when they say months. This doesn't mean February, March. When they say Motobana in Northern Soto, they don't mean Obana January, February, March. He doesn't see the calendar month. Cessation of months which means lunar months, and thus is called the cessation of menstruation. For you to say somebody is in menopause, it must be she must have spent at least 12 months without seeing any menstruation. So the diagnosis can only be made retrospectively. If she is still within 6-7 months after the last menstruation, we call that she's in the climacteric. She might be one of those who will have late menopause. We'll describe it later. So, but if 12 months can elapse without seeing any period, there are no chance that you can never see period anyway. And that's why the average from studies, majority of women, although 50 is taken as the most number, literature says 51 years is the average, but it's a range. Doesn't mean everybody at 51 will have this, but majority of people at 51 years, the ovary will stop functioning. There will be primary ovarian function cessation and permanent end to fertility. So there's no way that you can, after 51 years, majority of women can have fertility. They will be infertile. And after menopause, there will be some physiological and structural changes that happen. That's why this webinar, to educate you about that, to give you knowledge about that, because knowledge is power. Knowing more about menopause and changes in your body, the changes that your body is undergoing during this transitional period, will definitely make you feel more control of your body and control the menopause. You know, menopause by itself, I must say, is not a disease or a condition that can be cured. They say she had menopause, now she's cured. It's a natural and expected phase of life that everyone will have to go through. So everyone should know that menopause is a milestone that she might have. Some women will go through menopause with ease, while some will need treatment in order to cope well with this condition, symptoms of menopause. As female lives, with improvement in condition, the life expectancy of a woman is increased, such that, like in the beginning, I've said that most women will live about 1/3 of their life in menopause. And that need. Jolene, please stop doing what you are doing. Please. You did that in previous webinar also. I don't know how you do that. Please, I'm requesting you. Stop coloring here. As a woman approaches menopause, you should be given this knowledge that I'm trying to impart here. I'm showing you a picture of a woman. On the left-hand side, you can see this is a premenopausal skin and postmenopausal skin change in every woman. And within this knowledge, women will tend to accept that some structural changes will have to happen in her body, and that will be a milestone. So if you see some changes happening in you, you must know that you are not alone. People are undergoing those changes. Your body is going through that process because you are at that age that you should be in menopause. there will be some changes in the body, somatic changes, and changes in the physiology itself, which we'll touch as we go. The physiological changes that happen, which are obvious, is that you realize that menstruation, no more menstruation. Secondly, you realize that reproduction, you can't reproduce anymore. You can't reproduce anymore. No more children. Because endocrinologically, there are no more eggs in the ovary. There's a depleted ovarian reserve. Those 400,000 eggs you are born with, they are all gone. And there are other things that psychological changes that undergo with menopause woman. And this, I think I'm happy. I hope there are still men in here. To treat psychological changes, you need to educate men about menopause so that they can understand the psyche of a menopausal woman. We see a lot of social ills because men don't understand what a menopausal woman is going through. And this psychological, it goes with the social class and the culture of individual. The literature says that Blacks tend to cope more with menopause than whites. And the social class, the higher the education, the better the worse they cope with menopause. And the lower class, they cope better with menopause, which is unexpected, but it's like that. And there's somatic structural changes that you can see in the body, that this body part used to be like this, now it's like this, it has changed. It doesn't mean just deteriorate, it just changed to cope with the age. Some of the body changes are your skin. You can see that the skin of a menopause and the skin of a premenopause, they differ. You start to develop wrinkles. It's not no more smooth as you become. There's loss of subcutaneous first. And because of the dominance of male hormone, the androgens than estrogens, you start to develop hair where men usually develop hair. Some will just have some beards, 1 or 2, 3 beards will develop. And you'll find that even you can even change your voice because of the dominance of male hormone over the female hormone. And on the bony skeleton is something that we'll discuss later. The bony skeleton undergoes what we call osteoporosis, which means porous bones. The bones becomes weak, brittle, and break easily. And there are also other changes that you can realize in the cartilages, which are joint changes. The cartilage in the joints, because you have been living for so many years, there will be synovial fluid depletion and the cartilage thinning. That's why most of them, they've got osteoarthritis. They limp because of there's no more synovial fluid. Synovial fluid acts like a grease when the bones must not be bone over bone. And the articular cartilage also, it makes smooth rotation of bone over another one. But with menopause, which is consequence of age, not estrogen, it's just because of age, because this joint have been flexing and extending over many times. It doesn't have synovial fluid, doesn't have articular cartilage. Now it becomes painful when you move certain joints. That's why most of them, they limp, they use sticks. And the mind changes in menopause. The cognition changes. The psyche just changes. That's why I said you need to educate more men to be able to live with a menopausal woman. We see a lot of social ills these days where people after menopause, after being married for 30 years or more, they start to separate. Not because they are not compatible. It's because the man doesn't understand what this woman is going for. He thinks the woman has changed. Of course, he has changed, but you must adapt with that changes. It's some of the changes that a woman cannot control it because it's not herself who does that. With a little management or couple management, if a man understands, they can cope. And one of the things that mostly women come with, which I see them very much coming into my practice, is genitourinary changes, changes in the genital system and the urinary system. That's called genitourinary syndrome of menopause. It used to be called vulvovaginal atrophy, but now it's no more called that. It's called genitourinary syndrome of menopause because of the urinary and the genital system is aging. We'll discuss a little bit of genitourinary syndrome of menopause. as we go. I said structural changes, skin changes. I showed a picture of a menopausal woman here. If you've got an AI mind, you can trace back how the woman used to be before. You can see that this woman was not born like this. There's some changes. There'll be hair recession. You start to lose hair, and they think it's because of going to the salon. It's not because of going to the salon. It's because of male dominance of hormone that you lose hair. That's why most men with a lot of androgen, they lose hair on their head as they grow. They become bald. And you start to grow facial hairs. You start to have beards. There won't be as many as in men, but there'll be one or two beards will develop because of androgen dominance. And one thing difference between men and women in skin changes. You know, estrogen makes women to develop, to deposit fat if they become fat. They deposit fat on the breast and on the buttocks and on the thighs. Women never deposit fat on the abdomen. Men, when they get fat, when this man has got tenders, this woman, that's where men develop, because that's where their hormone, their endocrinology allows them to develop fat. They don't develop big buttocks and big thighs and big breasts. They might be slight gynecomastia, but not big breast. But women, they're different. If they get fat, they develop fat on the thighs, and they have calves. They develop breast fat on the breast. And again, mostly, they develop fat at the back. They've got a big buttocks. That's where women develop fat. Women hardly develop fat on the abdomen because it's a woman premenopausally, she develops fat here. But at menopause, because of dominance of male hormone, you may find that women will start to develop fat on the abdomen. It becomes like a man. And he loses fat on the bums, becomes flat at the bum. The breast becomes flappy and falls down, and she loses the calves that she used to have. But that's what menopause does. You sort of develop the androgenic type, the male type of body distribution of fat. I want to remind you again before I go further that we divide menopause in this way. When we say this woman is premenopause, she's not in menopause, she's premenopause. It's between 40 and 45. Those are the women that usually comes for infertility because they married late or they're following career. They are not infertile, although I said they've got a chance of having congenital abnormal baby, but that chance is not very high. Majority of them do conceive very well, even without ovulation induction. So some will need assisted reproduction. But around menopause, which is called perimenopause, the difference between perimenopause and menopause. Perimenopause means around menopause, which I said the average is about 51 years. Then those women, fertility is not encouraged for various reasons. That's the area where we call it climacteric. So with climacteric, we divide it into between 40 and 45, where fertility is still safe, and perimenopause, where fertility is unsafe or impossible, not impossible. So the average age, let's agree that it's about 51 years. And menopause is a retrospective diagnosis. You can't say a person is menopause if she hasn't finished 12 months without menstruation. And there are some women, what all people are saying, this is a normal distribution curve, a Gaussian curve. There are some women who will have what you call early menopause between 40 and 49, while the majority I said is 50, 51. They had earlier menopause, while other women will even undergo what they think is menopause before 40. They've stopped menstruating before 40. If you stop menstruating before 40, it's not within climacteric and it's not perimenopause. It's called premature ovarian failure. The ovary just failed prematurely, and there must be a pathological reason why they fail prematurely. More often, if you investigate, you find that reason why they fail. You're not in menopause, but endocrinologically you behave like a menopausal woman because you're normal menstruating, the estrogen level is low, the FSH is high, but it's not classified as menopause. Of course, there will be some women who will be far above 51 years, up to 55 years, still menstruating. That's are called delayed menopause. There will be few outliers. There will be those with early menopause, with delayed menopause. That's why from 40 to 55 years, that's expect one to be menopause. My majority, I say, they will fall within that 51 years range. There are abnormal types of menopause, which is not premature ovarian failure, it's truly menopause. Premature ovarian failure usually is a neurological condition that can be investigated and treated and corrected. The abnormal menopause as premature menopause that are usually caused by something externally. Surgical menopause. For some reason, a woman of below 40 is removing a uterus and removing her ovaries for some other diseases. If you remove them surgically, then you automatically go into artificial menopause, which is a pathological type of menopause. It's not a physiological type of menopause because many women these days, they can have diseases that warrant them to lose their ovary. They might have ovarian tumors, ovarian cysts, endometriosis, which affect the ovaries, and the doctors have to remove the ovaries. That will be surgical menopause. Or they might have a disease or a tumor that needs radiation. Radiation will radiate also the ovaries, and the ovaries stop producing estrogen. That will be radiation-induced menopause. There's some drug that is taken for particular diseases might affect ovarian function and cause menopause before 40 years. That will be truly menopause, but it's an induced menopause. Let's go to symptomatology. The symptomatology of menopause are divided into three main components. The one symptoms that are related to the ovarian activity and estrogen deficiency, lack of estrogen, are hot flashes. The first thing that a woman will complain is that's got a wave of heat that sweeps through the face and neck down to the chest, and it comes and go. And they also have this tendency of perspiring, even if the weather is not very hot. This is the symptoms that keeps them day and night, and they keeps them sleepless night, hot flashes and perspiration. And again, in this socially, they've got what we call atrophic vaginitis. Atrophic vaginitis means the genitals, the mucous membranes, and the glands in the genitals, they become atrophic and start not producing secretions, and they bleed easily because the mucous membrane is thin and sex become painful and they bleed during sex and they've got no orgasm. That's all symptoms of atrophic vaginitis. We'll go to it later when we discuss GSM. So these are because of decreased estrogen deficiency. They come early, and there are other late changes that will going to affect various organs like skeletal changes, the breast changes, the skin changes, and other changes, which we'll describe part by part. Number two is socio-cultural factors. Depending on the social class, where does it become? Depending on the environment, the upbringing, the time. Urban and rural people don't take menopause the same. Africans and non-Africans, they don't have similar symptoms. They don't worry much about them. Like blacks don't worry much about hot flashes, but whites worry a lot. And psychological factors, which it depends on the character of a woman. Some women are strong. Women are strong. They will not be affected by menopause. Their character, their psyche, their mood will not be affected by menopause. Some majority, their psyche is affected by menopause. Let's touch a little bit on this, which is caused by estrogen deficiency, which are immediate signs and symptoms of menopause, which conveniently can divide them into two, into immediate short-term ones, which do not last more than 5 years. These hot flashes and night sweat. Hot flashes and night sweat will not last forever. Majority of women by 3 years, 2, 3 years, they no more have hot flashes and night sweat. They are self-limiting, but they're the early signs. And there will be the late signs that are not self-limiting, will be lifelong, which is those psychological memory, physical changes. The memory, you can see it now. Most menopausal women don't have a very good memory. They put something here, keys here or something. Once in a while, they've forgotten where they've put it. Their mood, they've got mood swings. They're easily irritable. And there's some physical changes like we have seen in that woman's body that you can see that this skin is old, this spine is caving, and urogenital aging, part of it is genitourinary syndrome of menopause, and the atrophic vaginitis that I talked about, which affect this libido and sexual dryness. And the body changes are what we see here. This is a normal bone matrix picture. Strong premenopausal bone. But after menopause, the bones become porous. They could hold, it's like a sponge. It's called osteoporotic. What makes this bone? Because throughout our life, we form bones and we erode some other bones, which means there's bone formation and bone resorption. Under normal, before menopause, there's more bone formation than bone resorption. That's why there's bone growth and bone strength. But at menopause, things turn around. There's inverse. There's more bone resorption than bone formation. And there are two cells, some others are called osteoblast and osteoclast. Osteoblasts are building bones. Osteoclasts are destroying bones. So we've got more osteoclastic activity, bone destruction, than bone building. That's why the bones become like this and become osteoporotic and brittle and breaks very easily. So this is one of the late sequelae of menopause that people should try to prevent, because consequences of osteoporosis are hard to bear down. The bones are friable, they are weak, they are brittle, they break easily. And one of the late sequelae, which women complain about now, as evolutionary blacks used not to complain about it, but now they complain a lot, is the sexual discomfort due to vaginal changes that happen, genital changes. The mucosa, the lining of the genital, it atrophies, it becomes thin. And this is a layer that produces mucus and secretion. It stops, this mucus secreting capacity decreases so much that we can just say it doesn't secrete enough mucus for lubrication, resulting in a dry and painful sex. And the cervix anatomically, which is a stimulated organ that happens during coitus, it also flushes and becomes thin and atrophies and regresses. So sometimes the husband doesn't reach it, or it doesn't reach the sensation that it's supposed to sense. That's why the woman does not reach orgasm very easily. The epithelium becomes thin and dry. That results in traumatization and infection, because during intercourse, there's trauma there and it prone to infection. That condition is called senile vaginitis. There's a vaginitis of the salinity. There's this senile, and I don't think women like this word that they've got senile vaginitis, because nobody wants to be senile, but it's called senile vaginitis. And also late sequel in the urethra. Urethra is the pipe that takes the urine out of the urinary bladder to the outside. The mucous membrane that lines the urethra, which is called urothelium, it also becomes thin. It atrophies. And as it atrophies, it goes up to the valve. You know, in between the bladder and the urethra, there's a valve, which is called urethrovesical valve. That valve becomes incompetent because there's no more thin mucus there. There's no thin mucosa there. It doesn't close properly. That's why a woman in menopause, if she increases intra-abdominal pressure, cough or strain or lift heavy object or run with a full bladder, some urine trickle out because the valve becomes incompetent because of atrophy of the urethral epithelium. More often, if they examined, they find that the woman says, I'm postmenopausal, but whenever I go to the toilet, if I wipe myself, I see some blood. And she thinks that blood is coming from the endometrium. It's not coming from the endometrium mostly. It's usually the blood coming from the mouth of the urethra. It is a really polypate evasion of the urethral opening, which is called urethral evasion or urethral caruncle, that if she wipes, it bleeds easily, which is due to estrogen deficiency. And it also because urine in itself is acidic. When it passes there, in the inflamed epithelium of the caruncle, it bends there. So you find that she's got terminal burning on micturition. Once she urinates, urine is painful. And even sex also will become painful. It becomes dyspareunia. And again, one other thing, generally, the blood vessels that carry the blood, they must have some form of pliability. They must be compliant. When the heart pumps the blood in, the blood vessels must dilate. When during diastole, they must come down. They become rigid like pipes. That condition is called arteriosclerosis. That's why, because they're hardening and stiffening of arteries. And usually there's a buildup of fat inside these arteries, reducing the lumen of the artery. That in itself, it increases the chances that when you take a blood pressure, it becomes high. That's why most postmenopausal women, they're prone to blood pressure, high blood pressure. But because of the lumen decrease, blood flow to vital organs is diminished in that way. This is a picture of a caruncle that I showed, that there's usually evasion of the urethra at the urethral opening. That woman, when she wipes, she sees blood. Blood is from the urethra, it's not from the where menstrual blood comes from. And looking at this artery, this is a normal artery where the blood flows. But during menopause, there is arteriosclerosis, which is accumulation, the stiff vessels with the accumulation of fat plaque around them, that reducing this lumen and the pliability of this vessel, that reducing blood flow to the kidney, to vital organs, and prohibiting, predisposing it to hypertension. I've told you earlier on that this is a self-limiting disease, and intermittent heat, that wave that blows through the body, usually start from up downwards, which is just a consequence of vasomotor reaction of estrogen deprivation. And it's accompanied by night sweat and sleep deprivation. Night sweat with deep deprivation in menopause, and you are sitting next to the partner who is snoring here, then it must be horrible for a postmenopausal woman that to have sleeplessness and is sitting with an old man who is just snoring next to her, is sleeping. So, and that's why they develop a lot of psychological problems. They become panic attack and palpitation. 50% of women will have these hot flashes for more than 3 years. There's really a cascade of events and psychiatric symptoms. So because if you haven't slept the whole night, the morning you are tired, you're fatigued, you have diminished drive, and sometimes they feel even dizziness. They've got easy dizziness and loss of daytime energy because during the night they didn't sleep. They were having hot flashes. So they're always insomniac, sleeplessness. During the 3 o'clock, she's awake because she's listening to these hot flashes. And that during the day, she doesn't have the ability to concentrate very well. And thus she start to have mood swings. The mood fluctuates. You can't predict a postmenopausal woman. And a person with mood swings, mood must be directed towards somebody. And you direct it usually mood to a person closer to you. Who is the person closer to the postmenopausal woman? The partner. The mood is directed towards the partner. Then the partner start wondering, hey, nowadays when I talk to her, she's always not understanding. Just answers me the way she wants. Because mood, she becomes easily irritable, a postmenopausal woman, and apprehensive. And that's why I said, with this, you need to educate men. You must educate men how to do this. If the men can understand how to live with a postmenopausal woman, the anxiety and depression and feeling of inadequacy that's there in premenopausal woman, it will go away. Because menopausal women, they think they have been abused, they have been neglected, because that's the feeling they need more attention at that time, because that's because of that they become paranoid. They think the husband doesn't like the husband, but because men are not educated about this, then they move away from their wives. That's when they make things worse. That's the time that you must get closer to her and tell her that we are together. She mustn't feel that paranoid. By paranoia, I mean a mental disorder that's characterized by distrust and suspicious. A postmenopausal woman is very suspicious, Anything that you do is suspicious. It's like anxiety. She always has some form of anxiety, which is an emotional characterized by feeling of nervousness and worry, uneasiness, often anticipating future threats, and they are more anxious about their children. That's how they spoil the marriages of their children, because they just think their children, where they're living with their spouses, they're not living better. And they start to feel their noses in those affairs. And that's how they spoil things. And they get easily into a depression. Depression, usually a major depressive disorder, which is a mood disorder characterized by persistent sadness and loss of interest and difficulty in functioning in daily life. So menopausal woman doesn't have that stamina, is fatigue and forgetfulness is one of them. Of course, altered libido is a given. And that altered libido impairs the interpersonal relationship, usually between husband and wife. That's why I've said that it's a social norm these days. It's not uncommon to find that a couple which has been together for years, when children are all out in an empty nest, they are all finished their university education, tertiary education, they remain two here. We hear that now they are separated. The woman has gone to the children, and children accept such things. It's because the men and women in menopause need to be taken on a seminar to understand how to live with a menopausal woman. I think in one of my seminars, I'm going to call a psychiatrist or psychologist to come and deal with this early, that if you've got a menopausal woman, understand it. Psychosocialization problem. Even at the church, at society, my father, she lives alone. So there's a lot going into a postmenopausal woman that needs to be addressed and accepted. So let's touch a little bit of genitourinary syndrome. We're not going to get into details because it's going to be touched when we touch sexuality in menopause. I think in part 3, we'll discuss sexuality in menopause. Let's just talk about it because it's relevant here. Genitourinary syndrome of menopause. This is what it is. It's got the genital symptoms and urinary symptoms. Can I request people who are keep on throwing here not to throw here? Because there are people who, when they've got children, please don't do that, because I don't know how to stop you to do that. I'll learn how to stop you to do that. They've got one. On the left side is vaginal symptoms. On the other side is urinary symptoms. That's why it's called genitourinary syndrome of menopause. It's a condition that affects women during and after menopause and is caused by decreased in estrogen level, leading to changes in the vulva and the vagina, and the lower urinary tract. These changes that I'm talking about, they can result in a range of symptoms. They are many. The ones that you see, it's not even half of them, which have got genital, which are sexual, and urinary. All the term for this was called vulvovaginal atrophy, but they don't like it because it's not only the vulval vagina that's affected, there's also urinary system that's affected. It's vaginal dryness, usually even during sex is dry, and burning. Without infections, it's got burning in the vagina because of lack of those natural bacteria that are called the lactobacilli that keep the vaginal pH acidic. Now the vaginal pH become alkaline And if it's alkaline, it's prone to opportunistic infection, most especially the fungal infection, candida, will live there. No fungus will live in an acid medium. But because of lack of Dodelen bacilli, the pH changes to be alkaline and they've got prone to vaginal discharges. And this discharge is itchy. And if it goes out to the vulva, it's called pruritus vulvae. It can change the skin texture, find that the skin is sort of erythematous and reddish around the vulva. The labia become reddish and bleed easily and painful. And there's bleeding during intimacy and discomfort during intimacy because of this decrease in vaginal lubrication. As I said, that the mucosa is so thin because the vaginal mucosa is an estrogen-dependent mucosa. If there's no estrogen, there's no lubrication. There's dry sex. And the organs, all organs, there's atrophy of all organs, the labia minora, labia majora, and the vagina itself atrophying. The canal becomes smaller. That's why it becomes painful, and it causes what you call atrophic vaginitis. That's why I find that at menopause, because of atrophic vaginitis, the man is rejected. And when the man is rejected, the man is still strong. He goes for looking for greener pastures elsewhere. And that will be cheating at menopause when their children and grandchildren and daughters-in-law and sons-in-laws. How are you going to discuss that? The only way to make it not to Matlodi, please. Matlodi, please. I think I must look for these people and just remove them here. Because Matlodi is writing here. When the people have got this and the couple can understand because of changes that happened during that, and their husband start to do things that she's not supposed to, start cheating, that's where late divorce comes in, which was unwarranted. But if these menopausal symptoms, please don't. These menopausal symptoms were treated earlier, then we wouldn't be having this problem. We'll come to that when we treat it, when we're going to go further the same way. The urinary symptoms, they always have usually burning on micturition. When they urinate, urine is burning. It's burning because urine itself is acidic. The pH of the urine is acidic. And the bladder, the urinary bladder, like vagina, it's atrophic. It is not as compliant as possible. If the bladder was accommodating about 400 mils, now it can accommodate about 300 mils, then it's full. And it fills up very easily. That's why they've got frequency of urination. They go to toilet more frequent. Even during the night, they wake up to go into the toilet. While premenopausally, she would drink tea and coffee and sleep the whole night without going to the toilet. But now, even if she hasn't taken water, she must wake up once or twice to go to the toilet during the night. And that's what you call nocturia. Some women, if the toilet is outside and she fears that maybe there will be thugs or snakes, they buy a chamber and have a chamber and urinate in it during the night. They'll go and discard it in the morning. So while she be premenopause, they didn't need any chamber. And this, because of the epithelial thinning, they are easily prone to urinary tract infection. Infection can accent easily there. And as I've said, that the valve becomes incompetent because of the lack of thickness of that mucosa. And when she coughs, strain or run, a little urine comes out. That's what you call stress urinary incontinence. I think I've discussed stress urinary incontinence when I was discussing incontinence in one of the webinars. And another thing that bothers them a lot is which is a neurogenic, it's not a problem of the bladder, is that a menopausal woman, some of them, when she has got urine, bladder is full, she feels that now I need to go urinate. She must go and urinate now. If she can stop, she can postpone urination. If she postpones, the bladder will contract involuntarily and release urine. Edge incontinence, this agency, edge come from the word agency. It means it becomes urgent to go to the toilet and urinate. If she goes to the toilet, the nearer she goes to the toilet, the more the edge. Should she find that the toilet is locked, there's somebody inside there, definitely she's going to wet herself. This is a type of incontinence which is not only due to, it happens in menopause, but the problem is in the neuronal aging. There's cascade of events that happens during menopause. Hot flashes disturb sleeps. Sleep makes you no energy in the morning, no productivity. Then you develop mood swing and interpersonal relation. And that leads to today's trend. We call this post-menopausal social ills. Social ills that happen before menopause. Couples that used to love each other, hug each other, always together, they can't see each other now. There are divorce post-menopausal, separation post-menopausal, men and women sleeping in different rooms, can't be able to talk to one another. And this is not the problem of me, of women. It's the problem of the couple. People don't try to teach men that post-menopausal women are going through this and they need support. So if we don't give this support, will lead to social isolation and separation, not divorce, separation at late age. And the man will interpret it the African way and say, because children are grown up, now they're waking, now I'm nothing. I'm nothing. It's not because of that. It's just the psychology of postmenopausal women is somehow they need somebody to understand it. They've got this paranoia and just unjustified suspicion, mistrust of other people. Even you, they don't trust you anymore. They hide things for you. You know, Mokgekolo o fetela mogala with something. For what? He's not going to steal that thing. And that's why in South Africa, that has led to the terminology. There's a terminology which is only South African terminology. It's not there in English dictionary. It's not there in England anyway. They call it blesser and blessee. This word blesser and blessee is totally a South African term, not anywhere. In South Africa, there's a slang. They call it a slang because it arrives here. If it was in England, it would be one of the languages. It's a slang term for a wealthy individual. Often that wealthy individual is an older man who financially support younger women. Typically, we find even there are some students in exchange of companionship, because she doesn't have companionship at home, then she runs to become a blesser, or sexual favor. She supports younger men for sexual favor. This relationship is sometimes described as a modern day sugar daddy relationship, which is not wanted. The term blesser refers to a blessee, the term blessee. There's blesser and blessee. Blessee refers to a younger woman receiving support from a blesser. This is the evidence that this term comes from South Africa.
Blesser. One who blesses, one who bestows or invokes a blessing. Slang, South Africa, a rich man who offers support, typically financial and material, to a younger female companion in exchange for sex, friendship, etc.
This shows that this term blesser is typically a South African term. And that's why it's important in South Africa for us to propagate knowledge about menopause and sexuality. I like the songs, you know, although we need to teach more about menopause women. Also, a man also is a human being. So when you attack menopause, you must teach men and women. I'm happy I've seen men and women coming into this, because this young lady has composed a song which I like so much. It's got a message in it. You can listen to it. Those who knows Northern Sotho, they can understand it. If that is the case, a woman has got mood swings what's going to happen? We need to teach them both that, and woman must also understand Mahalawe. Mahalawe understand the old woman, and there will be harmony. And without good social interaction and education about menopause mixed with the endocrinology and psychology of menopause, we're not going to win this battle. We're going to have a situation where in most homes you find that beds are two. There's a bed for another woman, there's a bed for a man. In the same room, two beds. They can't occupy the same bed. Because psychologically, they just don't click each other. But that doesn't mean that a postmenopausal woman is the worst person. Because intimacy and love doesn't only revolve into bed. They can do so many things together. They can sit under the tree together. They can do everything together. Because I think men also, as they go through, women goes through menopause, there are also deterioration in their relationship. I always heard this as a man's cycle. Women get menopause from about 50. And you can see this age of 50, the man, the horse is still can run. If you can look this picture, can run. From now onward, from this age onwards, as the woman declines, the horse can still run. But there'll be a stage where up to 64, where the man is also up to 65, he also is old enough. He doesn't need a woman for things that he needs to need a woman for. He needs a woman for companionship. So after menopause, what's important is companionship, which with our culture, if we're taught very well, we went to circumcision schools, because the circumcision schools nowadays are just for money. They used to teach them how you are going to behave with your old men after menopause. And the social class have said that the higher social class as the one that don't cope better with menopause. The more educated you are, the worse you are during menopause. The lower social class, probably majority of them have been to school, which is a circumcision school, is a very school that they must write books about. The level of education I don't mean academic achievement, education about life. Because for you to be educated, you don't have to have a certificate. It integrated into the approach to menopause. So in medicine, we tend to medicalize menopause. We think we can treat it with menopause, with medicine. We don't treat it with menopause. We can treat it with hormone replacement therapy, but you treat it with education of menopause, which is one of the cardinal aims of South African Menopause Society. And as I've said, that the different races, you have got to approach them differently. And the relationship with the partner. You don't say a person who is now living with the partner for the first time, the partner was working in Joburg, he was in rural. You can approach it the same way as the partner the couple which was living together. So let's treat menopause not as a disease. We must educate ourselves to understand menopause and not put due pressure on partners. The wife try not to put pressure on the husband and vice versa. And sometimes diplomacy works. Because menopause mismanagement can break relationship. It is known to have drastic impact on the state of relationship, increasing dispute, lack of understanding, reduced physical activity and physical intimacy, poor communication, and eventually breakdown of relationship at a very late age. I think with good education, this is how menopausal people should be like. They should now be more romantic than ever before. I have told you that ovaries, which produce estrogen, the ova are finished. There are no more follicles. Then the male hormones, they dominate. If androgens dominate, then you start to develop hair, areas where men develop hair. You start to have what they call hirsutism. They develop some beards here. If someone will be on the chest, they will have voice changes and balding, and the hairline will recede. And I want to differentiate between this hirsutism and hypertrichosis. Hirsutism and hypertrichosis, although they all involve hair, these terms, they are different. They are both conditions involving excessive hair growth, but they differ in location and cause. Hirsutism, by definition, is excessive hair growth in females in androgen-dependent areas. Androgen-dependent areas are areas like the chin, the face, the chest, and the back, where men develop hair. They follow male type of hair distribution, but it's found in women. Hirsutism only found in women, and they develop hair in areas where men develop hair. It more often linked to hormonal imbalance, particularly androgens. We find that androgens are more than estrogens, like as said in menopause. While hypertrichosis, it can be there in men and women. It's excessive hair growth everywhere in the body. Like this man here has got hypertrichosis everywhere in the body. Find that a person is hairy all over. That's called hypertrichosis. So I just wanted to differentiate these terms, especially for the medics who are in here. The hair growth that disturbs them a lot, and people are making money out of it. They say it can bring your hair. There are a lot of gadgets in the market that is going to bring their hair. There's nothing that can bring back hair. They'll just eat your money. You find that you develop bald, but it's not as bald as a man would have, because although the amount of androgens is high, it's not as high as that of a man. If you used to have a hair that line that looks like this, you start somewhere you realize that I'm developing hair recession because of androgen dominance. It's not because of lack of estrogen, because of androgen dominance. Then with that, there's obvious skin changes that you can see. You don't want to deposit fat where women deposit fat around the hips and the buttocks and the waist. You've got central obesity and with wrinkles and some weight loss. And during menopause, because mood swings and depression, they either make you eat a lot or don't eat at all. So it can either cause obesity or weight, depending on what it does to you. But as I say, menopause doesn't matter what kind of life you were living before, whether you were beauty queen, excessively exercising, thin or obese, the effect will still be the same. Of note that I thought I should bring is women who, in themselves before menopause, they were having increased body mass index, which means they were having weight. They were, I don't want to say they were obese, but they were having weight. The women like these ones, they are going to reap the consequences of this type of body shape after menopause, and they are not likable after menopause. So that's why if a woman is in the reproductive age and start to gain weight, I advise her not to do that, because after menopause, she's going to lose all this subcutaneous fat, and the skin is not going to shrink. The skin is going to be redundant, and she's going to develop a redundant skin. If pre-menopause, you've got a fat too much even in the abdomen, when pregnancy come in, you're going to stretch the skin further. You know, pregnancy, as it grows, it stretches the skin. And as you stretch that skin, behind that skin, there are muscles which are called strap muscles. They extend from the rib cage toward the upper part of the pubic bone. There are two both sides. In the middle, there's an umbilicus. They're called the strap muscles. They're called rectus abdominis muscles. And the area where they meet together is called linea alba. It's going to separate. Like, let me show you here, just to listen.
As your baby and abdomen grows during pregnancy, the rectus abdominis muscles, or the six-pack muscles, are stretched apart, causing a vertical gap down your midline. This is a normal and healthy part of pregnancy, and 100% of mothers will have a separation at the end of pregnancy. However, if the muscles are stretched apart too far, it can cause damage to the connective tissues down the midline. By 6 weeks,
This is what happens during pregnancy. These muscles separate. And if they don't recall back, if you don't do postnatal exercise very well, at the end of pregnancy, you find that most women, because the involution doesn't happen, they don't do the Kegel exercise, they don't do postnatal exercises, they remain with a bulge here, which will need surgical correction for you to be like this. Or if it is a thin-bodied person, you can even see that area where the muscles have separated is wrinkled here. And this later will give him a hernia. That condition is called diastasis recti. It happens during reproductive years, but effect, you're going to reap them during menopause. What is diastasis recti? Let's explain it now, because some of the things that we see in menopause, they happen before menopause. So we need to start them from there. Diastasis recti is a condition where the two halves of the rectus abdominal muscles, which are the muscles that run vertically from the rib cage to the upper part of the superior ramus of the pubic symphysis of the waist bone, they run vertically. They separate because of the pressure of the pregnancy. And this separation causes a bulge in the middle, like I'm going to show you later. And this happens usually during pregnancy. And find that after pregnancy, you become like this. And this can cause a herniation or a hole there that one can feel that there's a hole between there. And as time goes on after menopause, we're going to have loss of subcutaneous fat, thinning of the muscles, and enlargement of this hole. So the intestines will start to go inside that hole. And somebody develops a hernia there. And the hernia can either remain silent, or it can be incarcerated, or it can be strangulated. Incarcerated and strangulated hernia are very painful and it becomes an emergency. If it doesn't cause incarceration or strangulation, it just becomes ugly to have a hernia in the middle of the abdomen. That's why if a woman has delivered, after delivery, they need to do some postnatal exercises to regain the pre-delivery state, which are taught everywhere. I just want to show you the effect in menopause. Most menopause are exposed to this because of the effect of pregnancy on them. They develop this hernia. And you can see when you say the
Menopause. Okay.
If that does not happen, majority of them develop what we call panniculus, apron belly. This is very common. Almost 90% of women at menopause, we have been pregnant before. At menopause, they've got lots of this subcutaneous fat, and the skin doesn't shrink together, and the abdomen falls down. But they want to have figures. They want to be like this. So after correction, which is surgical correction, they can still be like that. This is one of the unavoidable consequences of aging and menopause in a woman who is given pregnant. You can't avoid it. I can't say go and do ABC, you won't have it. It has to fall. The abdomen has to fall. But the only thing is that if you discover it early and you remove it early, the amount of skin that's removed is less. So the earlier the person does that, premenopausal, the better, because this apron belly is the effect of the childbirth. And you can't stop women from giving birth. But women don't want to be disfigured. They don't want to have this hanging abdominal wall, which is called apron belly, because of the perimenopausal or submenopausal loss of fat and redundant skins, oversized skin. And because of lack of estrogen, they've got this loss of subcutaneous fat. If it was a very hefty, obese woman, then it could go up to the level where it approaches the knees. In that way, the operation becomes bigger. This is one of the unavoidable things. I can't say do ABC, you'll avoid it. One thing I can say is that there are methods to reduce this, to treat this. I think, me personally, per month, I think, or in 2 months, I must treat one woman where I'll have to do panniculectomy to remove that pannus. I remove the skin as much as this one for those who are bigger, or smaller skin for the woman who has got a pannus small like this, or in some women who are like that, who are big, which I don't wish they come to me, but they come to me, I can't deny them, where you get to take the skin from the back up to the front. And in this one, I removed the skin with 3.4 kilograms, which is a big skin. This is a 3 or 4 hour operation. But in this case, I'm just to enlighten that these things are there. You can't avoid it. Panniculectomy, you can't avoid it. If it happens to you, it happens to you. It's there in everybody. You're not alone. And this operation it takes a lot of time to me. It's one of the major operations that cosmetic gynecologists do, just to show you how it is. You see, this video is misleading, you know. It's like there's no bleeding. This operation can bleed a lot. It's not bleeding like that. I do one every month. It can bleed a lot. You have to transfuse the patient. And this is a thick skin that they can remove it. One advantage of it doing like this is that this skin is weight. If you have removed, like I've removed 3.4 kilograms there, this woman has lost 3.4 kilogram weight. She can feel relieved that I've lost weight. And you can see this is probably is more than 2 kilogram weight in panniculectomy. So the only way that the message I drive is that when you have got banners, go and do panniculectomy. Panniculectomy is not tummy tuck. Listen to me. Tummy tuck is a plastic surgeon. They do body contouring, they suck the vessels there. It's not a tummy tuck, they strengthen the muscle. Panniculectomy is just removal of the apron belly. Finish. It's got nothing to do with the muscles. So if you want a tummy tuck, you go to the plastic surgeon. If you want panniculectomy, you go to gynecologist. Most women want to be like this after panniculectomy, which they reduce weight and the physical appearance becomes better. I always try to integrate things. So now, if women nowadays, they are complaining about body changes that happens during menopause, and they're complaining about apron belly. But what will our children who at this moment are dressing, they are doing what you call exposure. They say stomach out and other things. When the stomach starts to fall, how are they going to cope? Because if she used to boast about having a nice abdomen and then she buy dresses like this, the day the abdomen, the stomach falls, how are they going to cope with those psychological symptoms of menopause? They're just going to go mad and crazy. Because what I think now, which is going on now, which I think is a disease, they exhibit, there's a tendency of exhibiting body parts, the abdomen. It is called, that thing is called exhibitionism. Exhibitionism is the tendency of exposing body parts to individuals, body parts which are not normally exhibited. And that's a mental disorder. That's what the psychiatrists discuss now. What did they project? Because things that happen now, you can know how they are going to project earlier on. Like now, we know that men and women, previously men used to live at home with the old women, with boys, women with girls, and marriages were going smooth because there was separation of duty. Nowadays, men and women sit together. There's this tendency after 1994 that they must just be the same, they're even equal. Then you've got GBV, because you lost the good education, you go to the bad education. I think they're not going to cope well with menopause, because I've had a certain woman from Jane Fairs who was complaining about body changes, and people complain about body changes that happen in her. And those who are understand Northern's so will understand this woman. She's very angry if we can talk about, because she's menopausal.
Like bo magajibo. Re ka se mere tlhalosa mo go jima ga lena. We are not going to explain ourselves from you. Mekhabe ke a rena, mekhabe ke a rena. O ka se gatlhana mo tsele ba ntha re hlenga re imiweni. O nana go sentse go gore le ke reng ke go fetola ke reng ga botsa gana mo go gore le ke reng go gore le ke reng gona ge ke imi o na le tokelo go kampusha matleng ka re ke imi, like who are you o mang ene bontse re tshaba le fetola re jumo le fetola re fo le fetola ra ha ke gore go fo ye tšweni ke go fo ja le go se le selo. We are lying, actually we are lying to you. After ba go ja taba go amala situation re no nne re godile re belege re tshaba le go le fetola go ra o hlengwa ga go mokhaboti wa matolo mara o butchike motho seno wa tsara sengwe ka para sa 26 mara wa ra.
To avoid to be angry like Dennis Makola here, I think panniculectomy is just treat it, they must just remove it. Let's go to the ovary. The ovary, we said the function of the ovary is to produce eggs. And after menopause, there's no more egg production. But doesn't mean the ovary cannot be sick. That's the time when the ovary get diseases. They get tumors. They either have cystic tumors, which are ovarian cysts, or solid tumors. Some are cancerous, some cannot be cancerous. But you can never know whether they've got a tumor or not, or cancerous, if you don't do annual pelvic sauna. Every postmenopausal woman every year should go and do a sauna of the pelvis just to assess that those ovaries are still intact. It's not that to say she must not remove the ovaries. She must keep the ovaries because they also produce androgens, and androgens are converted into estrogens, if I've said it. But this is the time to develop malignant, which is cancerous, or benign ovarian masses. The worst is if they become malignant, because if they become malignant, they metastasize, spread easily before you can see them. So you don't have to have symptoms of a mass in the pelvis for you to go and consult for ovarian masses, which means every postmenopausal woman every year should go and be seen by a gynecologist to see whether she doesn't have ovarian masses or not. If there are ovarian masses like you've got ovarian cysts like this, you must assess whether it's got a malignant or it's a benign one. And even if it's symptomatic or asymptomatic, it can be removed. Nowadays, it's easy. It can be removed through a keyhole, through laparoscopy or not, or through laparotomy, depending on the size and the skill of the surgeons. Because as we said, with aging, we've got decreased number of eggs, and the ovarian size must shrink. If your ovary becomes bigger after menopause, there's something wrong with this ovary. The cortex of the ovary and the medulla become shrink, and the little ovary, the eggs that are there, which are called corpora albicans, are of no significance. And that ovary is just endocrinologically not so competent to can lead to fertility, but is endocrinologically important. It produces some hormones, so it still is important. So a postmenopausal ovary, if you look at it, it's shrinking, it's got wrinkles on it like this, and it's not supposed to have some cystic changes. If it has cystic changes, these cystic changes might look benign, might look non-cancerous on naked eye, but it can change to become malignant in future. If any postmenopausal woman should make sure that every year she goes for pelvic sauna. And on pelvic sauna, if there's need for laparoscopy, this is I'm showing a normal postmenopausal ovary without any pathology on the right, which is this one. And this picture is an abnormal postmenopausal ovary, which needs attention to avoid development of ovarian cancer. The message I spread here, if you are postmenopausal every year, make sure that your pelvis is scanned. And you've got ovary, if you've got ovary, they are right. Now we come to that condition that's very common, which is called osteoporosis. Osteum means bone. Porot means porous, it's got pores, it's got holes. So that's why it's called osteoporosis, which means porous bone. These bones are hard bones, which are brittle. They've got a lot of lacunae. That's why I say they're spongy, not to say they're soft, they're hard sponge. Because of what I said, that as we grow, we keep on, there's bone formation. We keep on forming bones, and we keep on resorbing bones. We destroy bones. If bone formation is less than bone resorption, then you get osteoporosis. This is a normal bone on the left, and after osteoporosis, you can see how the bones looks like. It's got more porous. It shows it very well in this one, a normal bone and a porous bone. Normal bone matrix, and this bone, it breaks very easily. Any other bone, the spine, it breaks. On the wrist, it breaks. The worst fracture that you can ever have, which you don't wish to have, is if you have got a fracture of the neck or femur. Because fracture of neck or femur, they say it's not a public health issue because there are not many women out there with fractured neck or femur. Ask me why. Because after fractured neck or femur, they don't live long. Majority of them are in the graves. So it's a killer disease. It predisposes to immobility, chronic immobility, DVT, decubitus ulcer, bed sores, depression, and they die. And this type of fracture no orthopedic surgeon will go and do a hip replacement there because that bone cannot hold a prosthetic artificial hip. So there's usually no treatment, reasonable treatment for fractured neck or femur on the osteoporotic bone. So the message I'm bringing here, try to prevent as much osteoporosis as possible. And it's preventable. I'm going to tell you when we discuss the treatment for menopause with HRTs and calcium and exercise, how you prevent osteoporosis. One of the dangerous area where osteoporosis causes effect, a damaging effect, is on the spinal column. If the normal spinal column matrix bone become osteoporotic, then you have got effects that a woman start to bend like this, you develop a hunchback. We've realized that old women usually, they develop that. This used to be a disease of the whites. But Mrs. Uso, it's not for the whites. It's a lifestyle disease. The lifestyle of blacks and the lifestyle of whites these days are the same. Most women don't do the washing in their own homes. They don't clean their own homes. They've got somebody who's cleaning for them. And that person is the one who's not going to have osteoporosis of the spine and a hunchback like this or kyphosis like this. You, the master who has got somebody who's doing washing for you, is cleaning for you, you're driving a car every day, you never even carry your baby at the back, you are living the lifestyle of the white woman that you used to call Mrs. So as you grow, if you don't have enough exercise or prevention of osteoporosis, which I'll talk about during the third phase, you're going to go be like this. You realize the majority of women are like this. And you have a lot of fractures, usually at the neck of femur, which I said is the worst fracture, followed by spinal fracture, followed by Colles fracture at the wrist, and any other bone you can. You realize that because of these bony changes, the height, it does compression of the spine. Then you start to be lose height after menopause. It's either because of the scoliosis or because of kyphosis, but majority before for kyphosis, this hunchback. And this hunchback tend to change the center of gravity such that you want to fall. As you walk, you want to fall. So you need a stick to balance yourself. And these are all I say they're preventable. When the seminar comes for HRT, we'll talk to you to avoid this excessive loss of height because of the curvatures that happens in the spine of a woman. Either she has bent forward or she has bent sidewaysly because of osteoporosis. If she bends forward, it's called kyphosis or a hunchback. If it becomes S-shaped, it's called scoliosis or a C-shaped spinal column. Because of osteoporosis, a bone just changed from normal to abnormal because of lack of estrogen, calcium, magnesium, and other important ones. The spine of a woman should be as straight as this one, which is not osteoporotic. When osteoporosis comes in, then you start to have either scoliotic spine, which is S-shaped, or a kyphotic hunchback spine like this. This is a gradual process. It will happen over years that you don't realize that you are busy bending and bending and bending until people start to realize that you are bending too much. So this kyphosis, which is a condition characterized by excessive curvature of the spine, leading to rounded upper back or hunchback, can be preventable. But many factors can cause by it, but the majority is osteoporosis. The loss of height is due to collapse of the spinal vertebrae, spinal compression of the spinal vertebrae. And demonstrate this so that you can see it very well.
High energy trauma from a fall from a height or a car accident can lead to spinal compression fractures. The vertebral body cracks under great pressure. Compression fractures most commonly arise due to severe osteoporosis, a progressive loss of bone mass most often seen in postmenopausal women. The vertebrae become brittle and can collapse even during normal activity, leading to a spinal compression fracture. Another cause of vertebral fractures is a metastatic disease. The cancer causes destruction of vertebral body, weakening the bone until it collapses.
It's okay. Okay. Let me go to like this. This is how I was distributing the spinal compression fracture. And the prevention of spinal compression fracture is easy. What you should do is not to spend money on it. What you should do is to just to take exercise, walking, doing household chores, sweeping, cleaning the house, washing clothes, washing dishes. As I said, that most of you don't even wash their own dishes. There are people who wash their own dishes. And sometimes you might have to take hormone replacement therapy, which we'll talk about it later, which must be taken within 10 years after the onset of menopause. How many couples, postmenopausal couples, just take a walk? Those who are going to have spinal compression fracture, they always have cars. The women, when they go to the corner shop, they take a car. One thing that you must avoid is excessive curvature of the spine. These women in the third world, they don't have that curvature because they compensate it by the type of work that they are doing. They carry their children at the back. That increases the spinal tone and the strength of the spine. How many of women here you treat the spine have ever carried their children at the back? None, if not any. Carrying the children at the back, it increases the strength of the spine. It's like you're exercising your spine. You carry your children like a crosser, you push them on a trolley, and that is the result of this happiness now. You're going to bear it after menopause. Let's go to a little bit of pelvic floor changes. Uterus and the pelvic floor. You know, the pelvic floor is like a bucket where all organs in the pelvis stay. I explained this in the pelvic organ prolapse webinar that I have done. The changes in menopause, you've got what you call pelvic organ prolapse, urinary bladder prolapse, rectal prolapse, and prolapse of the uterus itself. And these conditions are usually concealed. Usually pelvic floor, they think is a milestone. If a woman has got bladder prolapse, rectal prolapse, pelvic organ prolapse, because other women have got it also, they think it's a milestone. So they feel something coming out. Usually when the women come to me, they usually sit, but they are sent to us urogynecologists. They've got no vocabulary to explain those things. They just say something is coming out. You ask, what's something coming out? He says, something coming out of me. You say, where did you bring it? He said, no, it just come out and stayed there at the door. Then I know that it's either as a pelvic organ prolapse. And I just explain a little bit. You can see if you've got pelvic organ prolapse, it's got stages. And a woman, I want to teach self-examination thereof now. If you've got a sagittal section of a woman here, this is the urinary bladder, the uterus, the vagina, the intestine. Let's talk about the prolapse of the bladder. If you see the relationship of the bladder with the uterus, the bladder is just at the level of the cervix. But if it prolapses, that's when it comes down to below the cervix. It's going to protrude out through the vagina. And if you put your finger in the vagina here and you feel that there's a ball coming out, a bulge coming out, that bulge is a urinary bladder. One of the signs that you can see is that the urinary bladder must excrete through the urethra. When you go to the toilet to pee, if you've got a bulging urinary bladder, which is a cystocele, some of the urine bypass this passage, the into the urethra. It stays here. Then you have got what you call increased residual volume. After you urinate, a lot of urine remain in you. And you can feel that after you urinated, when you stand up, it's as if there is still some urine. Then you go urinate twice or thrice on the same sitting. You have to urinate, stand up, and sit again and urinate because of this bladder prolapse. But one diagnostic feature thereof is that when you feel that there is a ball, if you put a finger in the vagina here, you must know it's a bladder. But if you don't, then if it's treated at that stage, it's easily treated at that stage because it doesn't damage the urethrovesical angle, this valve here. If you leave it until it comes out itself and it forces to look for treatment because now it's protruding through the vagina, it usually has a lot of damage on the valve, which is called urethrovesical angle valve here. And then once you treat it, then you develop with urinary incontinence. So anybody who puts a finger inside and feel a ball, repair it quickly before it damages other things. The other thing is the rectum, and there are also signs that rectum that prolapses. A rectum is here, and the feces must come through the anus into the rectum, through the intestine, into the rectum, into the anus, outside. If the rectum protrudes, it protrudes usually forward into the vagina and it comes out in the vagina. The only thing is that you can't feel it as such rectocele unless if it's full of feces, is that as the fecal matter comes here, it bypasses the anus, it must come out through the anus, it bypasses the anus and come and lodge beyond the anus. So when you go to the toilet to do number 2, you don't remove everything because there's a pouch in the rectum there which collect the feces. And you've got this feeling that you think you have evacuated your rectum, but you feel that not everything is evacuated. Once you stand up, you feel like you want to go again. Then you've got to go again and strain and push very hard, and maybe nothing comes in. Most women, they just develop a tendency that they must put the finger in the vagina to push this rectum up so that they can evacuate everything. Everything must come through here by pushing this up, because if it goes down like this, feces collect here. Most especially if it's hard feces, it's a rectocele, which happens mostly during menopause. You find it mainly during menopause, but of most importance, as most common, is the uterus itself for this woman who still have a uterus. You see, the uterus is just sitting up there, but with prolapse, a woman can find many various stages of prolapse. You can feel that I can feel my cervix is here. When I put my finger, it's like the cervix is near. Or if he doesn't know that it's cervix, she feels that there's something that I can feel here. Is the cervix coming? This is stage 1. It goes with stages. As time goes on, it will peep through the vagina here. And you can see that it's there. Now it starts to become dry and discharge, and your panty liner is always wet. Until most women, I wonder, they come to me already with the whole uterus out, which is called prosudentia, which, if you ask them very well, they have had those stages where they could feel that there is something in them. They could put a finger there and feel that there is something in there coming out. But they didn't consult because it was not giving them symptoms, except mild headache. Or if they ask other women, they say, oh, I'm also like that. But when they start to have prosudentia, that's when they come for consultation because of the damage that happened during childbirth on the pelvic floor. This area is called hiatus. These muscles are called levator ani. When the baby passes here, it causes so much damage that the consequence of that damage will be felt after menopause. So prevention of that pelvic is good conduct of labor. Avoid home deliveries. Do cesarean where necessary. Don't push before time. Good, because majority of the cesarean section is the case. If the baby is big, do a Caesar. If it's not big, it's going to damage the pelvic floor. And the pelvic organ problem is not going to happen now. It's going to happen after menopause. And after every birth, a woman should do pelvic floor muscle exercise, Kegel exercise. I hear women marry, keep off it. I must tie the abdomen. Why tie the abdomen? For nothing. Do pelvic floor exercises that the midwives will teach you and the physiotherapy will teach you. So the majority of them don't do that, and they come from various treatment modality for that, for various reasons. And the treatment modality that we do as urogynecologists, either for cystocele prolapse, we do anterior colporraphy. For rectal prolapse, we do posterior colporraphy. If it's uterine prolapse, we either do one of the two, depending on which one is suitable for which patient, because we individualize the patient. We either do sacrocolpopexy or saxospinous fixation, which are procedures that I don't explain here, which are all 2-3 hour procedures that are necessary and preventable, because pelvic floor rehabilitation after delivery can prevent a lot of postmenopausal consequences that
The pelvic floor.
To show you a little bit what you must do after, even if after birth, even now when you are seated, every woman who's here must do this twice every day.
Is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely. Note
the physiological changes that usually every postmenopausal woman should do every year. There are lipid changes. You must go and check for your lipid every year, because you have got increasing cholesterol levels in your blood, which will predispose you to deep venous thrombosis, which will predispose you to stroke. Most people, if you have got triglyceride and low density lipoprotein, just go for lipid profile. The lipid changes in the postmenopause because of lack of estrogen can lead to ischemic heart disease. That's why they've got heart attacks and strokes, because they don't check their lipids. And so every postmenopausal woman should go once in a year for lipid profile changes. It's a blood change. They take blood and see how your lipids are. If they are very high, you modify your diet, and with exercises, you can easily correct your lipid abnormalities. The digestive system, they usually have hemorrhoids. Why do they have hemorrhoids? Because they've got poor chewing ability. The intestines have got poor brush border. They don't absorb easily. They've got slow peristalsis. Hence, they become constipated. With constipation, which is caused by malabsorption, they push hard, very hard stools. They strain too much, and they develop piles. That's one of the common causes of pelvic organ prolapse, is to strain hard when you go to the toilet, and they develop these hemorrhoids. But if they eat well, they still have enough teeth, and they drink a lot of water after eating, then absorb well, the chances of developing hemorrhoids are less. The bad tendency is to treat constipation with pegative. Take tablets that makes you have diarrhea. That's the worst way of treating constipation. Constipation is treated by good diet, low residue diet, high fiber diet, and with fluid inside it. Because with menopause, you tend to see that every bone resorb. That's why you find that your teeth are longer now, because the gum has receded. And that's how you lose teeth, because as it recedes, it exposes the roots of the tongue. I just want to demonstrate here that in every body inside our body, our intestines are continuously moving in a process called peristalsis, and they're pushing food from the mouth towards the anus. In menopause, there's poor peristalsis. Peristalsis, if you have eaten a lot of fluid, you can hear the intestines say, is because of this perpetual movement of intestines inside here. There's weak peristalsis during menopause that result in formation of stools that are hard in the rectum, and they cause you to strain too much when you go to the number 2. And that way, as I said, it will give you hemorrhoids, which can be painful, which can bleed, and the treatment thereof is just diet. In conclusion, I want to say that we've discussed several systems, the bone system, which is touched a little bit of GMCU. In the second conclusion, as part of South African Menopausal Society, aim of promoting women's health and imparting knowledge about menopause and addressing things that are not commonly addressed in the lay magazine and educate women about menopause. We seek to empower you women with knowledge and support you to navigate this stage of menopause, how to support it, and by providing some comprehensive resources in the form of booklet and in social media. Social media is a very good educative measure. Hence, this webinar is one of them. I think for enrichment and references, if you visit my YouTube channel, which you just type Dr. D T Mahapa on YouTube, it will take you to my YouTube channel. You will find a lot of resources. Even this webinar, I'm going to put it on YouTube. You can access it there. So those who are like, I'll give them a link, but majority can access them on this YouTube channel, Dr. D T Mahapa. You just go to YouTube and type that. Even in Google, if you type there, Dr. D T Mahapa, YouTube, it will take you there. Or those who have got access to my Facebook page is Dr D T Mahapa. They'll find a lot of educational resources for menopause and those that are not for menopause. Thank you very much. The aim here is to get a healthy woman, not only African, but I'm an African. I cannot say I'm doing only for African. We want healthy women who can be functional to the society like this one.